The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. This is Jan Carlin. Thank you again for spending your lunch hour to listen and participate in this webinar, where we hope you will gain valuable information on dementia. This is the third and last of the series of webinars that have been discussed regarding non-pharmacological and appropriate pharmacological approaches when supporting a person with dementia. In this webinar, Dr. Maureen Nash will present on the circumstances when antipsychotic medications are appropriate. Hopefully you have been able to attend the previous webinars presented by Liz von Welsheim and Dr. Elizabeth Ekstrom, where non-pharmacological interventions were discussed and when to avoid the use of antipsychotics. All of these webinars have been or are being recorded and will be available in about a week after the presentation. These webinars are brought to you by the Oregon Partnership to Improve Dementia Care. The partnership consists of representatives of the Oregon Healthcare Association, Leading Age Oregon, Oregon Department of Human Services, Health Insight Oregon, Providence Elder Place, the Alzheimer's Association, and MOVE. We are also fortunate to have Terry Fagan with Consonas Pharmacy and Cy Simonson, consultant pharmacist, on our team as well. In the past few years, there has been a great deal of emphasis on long-term care settings to decrease the use of antipsychotic medications for people with a diagnosis of dementia. These are powerful drugs that have dangerous side effects and for the most part do not improve the well-being of the person living with dementia. The goal of these webinars is to emphasize the importance and appropriate assessment and how adopting a person-centered approach to care can enhance their lives. Today, I'm happy to introduce to you Maureen Nash, MD. Dr. Nash is a well-known physician in Oregon, where she is currently the medical director at Providence Elder Place in Portland, Oregon. Prior to her work at Providence Elder Place, she served as medical director of the Tuolity Center for Geriatric Medicine. She earned her degree from the University of Kansas School of Medicine and completed her residency at Dartmouth Hitchcock Medical Center in Lebanon, New Hampshire, where she served as chief resident. She is board certified in both psychiatry and internal medicine. She is passionate and committed to improving the life of older adults. She has served and serves on national committee and boards. Here in Oregon, she was instrumental in the development of the state plan on Alzheimer's disease in Oregon, or as we call it, SPADO, and she is an active member of the Oregon Partnership to Improve Dementia Care. After Dr. Nash's presentation, there will be a short question and answer period. When the webinar is over, you will receive an invitation asking you to evaluate the webinar to give us some feedback on today's presentation. So with that, thank you, Dr. Nash, and please start your presentation.
Hello, everybody. I appreciate your time as we talk about this important topic, the appropriate use of antipsychotic medications for those with dementia. This specific topic was chosen by the Partnership to Improve Dementia Care as part of the plan of 3 different webinars where we review behavioral interventions, medication interventions that don't involve antipsychotics, and then what was left to me was to talk about why or when would anybody want to use an antipsychotic medication in someone with dementia. And so for this talk, I'm going to review a little bit of the history of psychosis and neuropsychiatric symptoms in dementia. I'm going to review the FDA boxed warning that many people have heard about. I'm going to talk a little bit about the history of use of antipsychotics in those with dementia and how some of the concerns arose about using those medications. I'm going to talk briefly about why antipsychotic medications work and what it is that they do. And then I'm going to talk about the appropriate use of those medications, specifically when people are suffering with moderate to severe paranoia, delusions or fixed false beliefs, hallucinations, and aggression. You really can't talk about Alzheimer's disease without going back to the very first patient, Auguste D. And there have been several different descriptions of her care. She was the first patient who was actually diagnosed with this illness by Dr. Alzheimer when he looked at parts of her brain on slides. Her symptoms began when she was 51 years old and followed the pattern that we commonly see in people who have Alzheimer's disease. But she came under Dr. Alzheimer's care specifically because she was suffering with hallucinations, delusions, and what they called psychosocial incompetence that I think actually references functional decline. And specifically, she had terrible paranoias that her husband was having affairs. She thought people were trying to kill her. She thought people were torturing and killing children around her. And an example of how she was described is she becomes excited again and screams terribly. She is in a state of fright, anxious, and completely disoriented, violent towards everything. And those are actually not unusual symptoms in people who have Alzheimer's. The next two slides review some of the symptoms that people who have dementia have, some of the behavioral symptoms that are not really part of the memory or cognitive part of the illness. This particular study by Craig was published in 2005, and it looks at a subset of people and tells us how often did this group of people with Alzheimer's show symptoms of these neuropsychiatric symptoms during their illness versus how many were shown in the last month. So, for instance, at any point in their illness, 50% of the people that they studied had delusions or fixed false belief. For instance, that somebody was trying to persecute them, or that somebody was in the next room was being targeted or tortured. And in the last month, 35% of the people that they looked at in this survey had that symptom. So you'll see that the symptoms of delusions, agitation, aggression, depression, anxiety, apathy are not uncommon at some point in the illness. Irritability, excessive motor behaviors, sleep disturbance, and appetite disturbance. These are central symptoms that people with Alzheimer's disease have. And really, studies have shown that at least 90% of people who have Alzheimer's disease have some of these neuropsychiatric symptoms at some point in their illness. And in fact, it might be higher because it's not always easy to actually track people for the entire course of their illness. This is another study that's a little bit more recent. It came out in 2012, and it looked at several nursing homes in Norway. And again, what you'll notice is that the symptoms of irritability, mood instability, delusions, lack of inhibitions, agitation, aggression, these are all very common symptoms in people who have Alzheimer's. And really, because people have these symptoms, that is one of the things that leads us to treat people. My next slide is really just a sort of an airplane view of the worst case, right? What's the worst thing that could happen if somebody was paranoid and delusional and they had Alzheimer's disease? Well, you know, one of the worst things that could happen is that they harm someone. And so I don't show this because I think that this is the most common thing that happens, but it frankly isn't uncommon. And for every one of these instances where someone with dementia kills somebody else with dementia or kills another resident in a nursing home, another frail older adult, or harms a staff member, for every one of these incidents, there are many thousands of incidences of aggression that didn't reach this terrible point. And so that's really one of the main reasons we treat this symptom, because we don't want people harmed. And people who are suffering with paranoia and psychosis often can become aggressive because they feel like they're trying to protect themselves from a threat, even though the rest of us look at the situation and don't see a threat. Another reason that we treat people with dementia with medications is because aggression towards staff is a frequent occurrence. And often this is not severe or dangerous aggression, but sometimes it is. And this is a study from 1999 looking at nursing assistants at 6 nursing homes, and 59% of those nursing assistants were assaulted once per week. 16% reported being assaulted on a daily basis. And there are many other studies. And so this really is what leads people to look for treatments for people who have dementia. We want to treat this kind of aggression when it happens, and we want to prevent it from happening when we can. And it's not just the safety of staff members, but it's the safety of peers, and it's the safety of the person themselves. One of the most touching things I have found in my work with people with dementia has been things that the family members have said to me. And these are some of the quotes that people have said to me. I don't want my mom's last days filled with fear or terror because of the delusion that someone is trying to hurt her or steal her money. I don't want my mom to hurt anyone. If my dad knew what he was doing, he would be so embarrassed. Or I'm afraid dad is going to kill my mom. So these are the things that lead us to look at the need for medications. And whenever you're looking at nursing homes, you do have to consider regulatory issues. As a group, people who live in nursing homes are quite vulnerable. They're there because of physical frailty or because of cognitive deficits or a combination of both. And in 1987, there was a very important group of regulations that became established after surveys done across the country showed some real problems with the care that people in nursing homes were receiving. They found inadequate assessment of poor quality of life, violations of basic rights, and a failure to recognize and treat reversible causes of physical and functional decline. As part of this, one of the concerns that emerged was that nursing home residents were being drugged to control behaviors. And this particular group of regulations really changed how nursing homes are regulated and led to many improvements in the care that people who live in nursing homes receive. And as part of this, I do want to point out this was all before the class of medications called atypical antipsychotics even existed. And when people talk to me about their concerns about using antipsychotic medications, I frequently hear things along the lines of, you are just drugging people. And I would argue that that is actually very, very rare. I think there are times where people are given medications because they're having intractable pain or they're having really intractable symptoms of aggression, where you might give a person a medicine in the short term to help prevent an emergency situation. But long-term use of medications to drug people is fortunately fairly rare and isn't usually the purpose when somebody is prescribed an antipsychotic medication at the current time. One of the other things that I hear is that these medications should only be used in certain severe mental illnesses. And a lot of times people focus on the illnesses of schizophrenia and bipolar disorder. But actually, antipsychotic medications have been shown to be helpful for a whole range of illnesses. Certain people with major depression, certain people with obsessive compulsive disorders, certain movement disorders, and certain neurological illnesses all benefit. Symptoms are all benefited when people are treated with antipsychotic medications. Antipsychotic medications actually aren't specifically designed for just people with schizophrenia or just people with bipolar disorder. One of the other things that I've been told is, well, you know, antipsychotics are tranquilizers. And I think that comes from a very old classification of medications. We used to call some medications major tranquilizers, and that was the older or typical antipsychotics. And then we had what were called minor tranquilizers, which included medicines like Valium or Ativan, lorazepam, and diazepam. That actually, the word tranquilizer in that context was really used because of the side effect of sedation that some of the medicines in those classes caused, and not because those medications actually were tranquilizers. CMS, or the Centers for Medicaid and Medicare Studies and Services, in 2012 was looking at the use of antipsychotic medications in people who live in nursing homes and in people who have dementia. And they really were concerned and wanted to make a concerted national effort to make sure that medications were being used appropriately. And so they formed this national partnership, and every state has a state chapter, and that's the group of people who are sponsoring this webinar. They developed and have been promulgating a training series called Hand in Hand, and really have tried to focus and help everyone else focus on person-centered care, prevention of abuse, and providing high-quality care. When it first came out, the only goal that they measured as part of this partnership was to reduce antipsychotic use by 15%. And at the time, I was a little concerned because I thought it would be more useful if they were measuring quality of life or the quality of care that people received, or if they were measuring suffering and whether we were decreasing that or whether we were actually preventing abuse. And over time, CMS has broadened what it looks like, although they still remain quite focused on the percent of use of antipsychotic medications. And as part of that, they publish every nursing home's use so that you can look at that and potentially conclude something about a nursing home. And the focus that CMS has on antipsychotics really started in a major way in 2004 and 2005 when the FDA put boxed warnings on, first on risperidone, then on all of the atypical antipsychotics that were used at that time. And the warning was for an increased mortality when those medications were used in what is called off-label use. Interestingly, whenever the FDA does put in a boxed warning, they do list on their website all of the information they used to that led them to put that warning on medication. So you can actually go to the FDA website and read that. And I did that in 2005. And what I found was that the average age of the people that they were looking at who died was 85. They weren't tracking at all what medications were being used for, and specifically they didn't look to see whether people were being treated with for psychotic symptoms. And then the cause of mortality was all over the board. So some of it was infectious disease, some of it was cardiac, some of it was GI bleeds, some of it was strokes. It was just all across the board, which doesn't actually suggest that the medication was the central cause of the mortality, because in general, medications would all be causing a similar cause of mortality. And so, because I was concerned about that, I reached out to Senator Jeff Merkley and his office in Oregon, and he arranged for me to have a conversation with the two lead psychiatrists at the FDA at the time, Dr. Loughran and Mathis. And what they told me was that they didn't actually understand the signal. So they didn't actually understand what it was that was causing this increased risk of mortality. They let me know that the warning was based on all of the data collected prior to 2005. So it wasn't, they didn't update the warning based on any new data. They did also reinforce my understanding that it was unclear why people were being treated with antipsychotic medications. They didn't exclude people who were at high risk of death, such as hospice patients who are routinely treated with haloperidol for terminal delirium. They didn't exclude people with delirium, which has at least a 50% mortality rate. They did point out that the risk was highest at the start of treatment. They theorized that they thought the risk was due to excessive sedation, although they were unable to tell me why they thought excessive sedation might cause a heart condition or a stroke. And they pointed out to me what I already knew, which is that the box warning, which is sort of referred to as a black box, is not a contraindication to using those medications. They pointed out to me that those medications were certainly appropriate at times to be used in people who had dementia, and that the FDA in no way was trying to imply that they should never be used. And that, actually, I knew that, but one of the things that, as a psychiatrist and a geriatric psychiatrist in particular, I had found is that people were very unfamiliar with that. People really were interpreting the FDA warning as saying that we should never do this, when that isn't what the FDA was implying. What happened after the FDA put its warning out? Well, actually, a very similar thing that happened when CMS started looking at nursing home use of antipsychotics. The usage decreased. There was almost a 20% decrease in the use of atypical antipsychotics by 2008. So this all started in approximately late 2004. By 2008, there was a 50% decrease in the use of atypical antipsychotic for those who had dementia. And interestingly, the use of atypical antipsychotics decreased for everyone, and not just those who were older, and not just those who had dementia. So tells us something we already know, which is when the government makes regulations, people react in ways that they think will be helpful for their patients. However, one of the main problems that I had pointed out to the FDA when I had the conversation with them, and that many other people had pointed out to them, was that they actually had put the warning on the newer antipsychotics, or the atypicals, when it was really the older medicines that were much more dangerous. And ultimately in 2007, the FDA fixed that. So that's all sort of dry background. But I think really the key thing for all treatment of patients and individuals is really that it be person-centered. And so the key thing when you have a loved one or who has dementia, or you're caring for someone who has dementia, the person who represents the individual, either themselves or their family member or their surrogate decision maker, really needs to talk to the prescriber about what are the risks of this particular intervention, what are the benefits of treating whatever symptom or sign is going on, and what are the alternatives to using a treatment. And that discussion should also include the risks of not treating. You know, there are some symptoms, delusions, such as it's quite common for people with dementia to think that they're missing objects that they can't find might be stolen. That's quite common. And often that doesn't need to be treated with a medication, unless, of course, the person becomes so upset that and believe somebody actually did steal it, and then they go and target the individual that they think has stolen their belongings. You know, that sort of helps you in that discussion, that informed consent discussion, so that you can figure out what's worth treating, what's not worth treating, what is really causing a risk to someone's quality of life. Common risks of no treatment of paranoia and delusions include the person themselves or peers being injured, staff being injured, people being evicted because their behaviors are placing people at risk. And social isolation is an underreported risk. One of the saddest things I ever found out about was a patient who had been treated at my hospital and was discharged back to a memory care unit in Oregon. And several years later, he again was having challenges, and he came to our hospital again, and another person from the same residence ended up being hospitalized. And the family members of this other person said to me, "Oh, we recognize that man. Everybody at the nursing home told us to avoid him because he was dangerous, so no one ever talks to him." So again, these are the kinds of things you really have to look at when you're trying to make an informed decision about whether to treat someone and what really is a quality of life. So, antipsychotic medications. Well, what about the FDA approval of medicines? What are antipsychotic medications used for, and why are they used? The FDA approves medications for a specific illness, even if the medication treats only the symptoms of the illness. Many illnesses, all we can do is treat the symptoms. We actually can't change the underlying course of the illness. So, for instance, insulin or metformin is used to treat diabetes, but doesn't really change the underlying course of the illness. Once a medicine is approved by the FDA, it can be prescribed for anything. And because it costs so much money to get a new indication for an existing medicine, often drug companies don't go back and do all the application to get an indication added. What physicians use is they look at how does this medicine work, what kinds of symptoms can this medicine help, are there published studies, is there evidence to show that this medicine is helpful, what are the risks of using this medicine, what's the benefit, and should I recommend using this medicine in my particular patient. Antipsychotic medications in particular work on the dopamine system and were discovered really when they were looking for an antihistamine. They were looking for a medication related to diphenhydramine or Benadryl, and they happened upon chlorpromazine, which was the very first antipsychotic. When they looked at that, they found that that medication worked on dopamine, and it lowered the amount of dopamine in the brain. And alternatively, it was also well known that cocaine and other stimulants increase dopamine in the brain and can cause psychosis. And so that's sort of loosely our understanding of why antipsychotics work. Antipsychotics are used for lots of things. One of the things that they work on in the brain is actually the vomiting center, and so it's a frequent treatment for people who have excessive vomiting, either from chemotherapy or certain GI illnesses. And so that's actually how they found these medicines, and that's what they look at. These are the old, and this is specifically true about the old antipsychotics. The newer antipsychotics, what are called atypical antipsychotics, actually work on serotonin, and through a very complicated chemical reaction, affect dopamine levels in the brain, but it's all through their action on serotonin. And so atypical antipsychotics as a class of medicines were developed to have fewer side effects than the older antipsychotics. And because of the mechanism of action, it was hoped that they would help with slightly different symptoms than just the psychotic symptoms that people suffer from. It was hoped that the atypical antipsychotics could help with associated symptoms that are seen in illnesses where people are suffering from these symptoms. So all of that is a lot of background and hopefully not too overly technical. What I want to review is, what is the evidence that antipsychotics actually might help treat agitation, aggression, or psychosis in people who have dementia? And in 2016, the American Psychiatric Association produced a 216-page report that reviewed all of the evidence. And what they found was there is at least moderate evidence that risperidone is successful in treating psychosis in people who have dementia, that risperidone, olanzapine, and aripiprazole, which are three atypical antipsychotics, are effective for treating agitation and aggression in people who have dementia. They found that there was insufficient information to suggest that quetiapine, which is also called Seroquel, is effective for treating any psychotic symptoms in people who have dementia. The one exception was people who have Lewy body dementia and Parkinson's disease dementia. There is evidence to suggest that quetiapine and clozapine, which are two of the newer antipsychotics, are helpful in that particular illness. When you look at behavioral and psychological symptoms of dementia overall, so for instance, the neuropsychiatric inventory that I showed at the very beginning of this presentation reviews a series of symptoms. And if you just count up all of those symptoms and weight them for the severity of those symptoms, there is moderate efficacy for treating people who have significant behavioral and psychological symptoms of dementia. There's moderate efficacy for using aripiprazole or risperidone. They found there's moderate efficacy for treating agitation and aggression with olanzapine and risperidone. They found that if people are having psychotic symptoms such as paranoia, delusions, hallucinations, that risperidone has moderate efficacy, and that overall the second generation antipsychotics had high efficacy for high levels of behavioral and psychological symptoms. What did the APA recommend? Well, they recommend that you do a good assessment of what are the risks, the benefits, and the alternatives of using this medicine in this particular person, starting with the lowest dose and carefully monitoring for side effects. If an antipsychotic is successful, they recommended that the decision about stopping or tapering off of a medication be person-centered, and that you get input from the person if they're able to give input, and if not, from the family and others who were involved in the daily life of the person. Past experience with antipsychotic medication trials and tapering attempts should be considered. And in my experience, that's really important. If you've tried to taper somebody off of a medication 2, 3, or 4 times, and every time you do it, they have significant increase in suffering after you do it, then at some point, you really have to wonder if you should keep trying. When an antipsychotic medication is being tapered, they recommend that symptoms be assessed at least monthly during the taper, and that even after the medicine has stopped, monitoring continued for a minimum of 4 months to look for signs of recurrence or other problems that might be emerging. If symptoms recur when somebody has been tapered off of an antipsychotic, they recommend reassessing the benefits and risks of treatment for that particular person. So that was based on a review of hundreds of studies and meta-analysis. And, you know, I'm just going to pick out a couple little nuggets from a couple specific studies to review here today. This is from 2 studies published in 2004, and it showed that for treating delusions and hallucinations, risperidone was helpful. Risperidone and haloperidol were both helpful, but risperidone, the newer medication, had fewer side effects. But interestingly, one of the things that they showed was in people who had dementia, a 1 milligram per day dose of risperidone was associated with a decreased fall risk, while a 2 milligram dose per day had an increased fall risk compared to no treatment with risperidone or treatment with higher doses. So it really just goes to the point of person-centered care, looking at this particular person, what dose works for them and what side effects, if any, are they having, and where are they in the trajectory of their illness, and what makes sense for them. If you look at 4 of the commonly used atypical antipsychotics, risperidone being used at a dose of 0.5 to 1 milligram twice a day, ziprasidone, or also known as Geodon, being used at a dose of 20, 40, 60, or 80 milligrams twice daily, given with food. Olanzapine, which is also known as Zyprexa, 2.5, 5, 7.5, or 10 milligrams once daily. Aripiprazole at a dose of 2.5, 5, 10, 15, or 20 milligrams daily. In general, a number of studies have shown that quetiapine is not useful for treating psychosis in patients who have Alzheimer's disease or a combination of Alzheimer's and vascular dementia. Lewy body dementia and Parkinson's disease dementia are an exception, and when you use quetiapine in those illnesses, you're often using a very small dose, such as 12.5 milligrams or 25 milligrams between 1 and 3 times a day. One of the biggest studies of Alzheimer's disease and psychosis is the KDAD study, the National Institute of Mental Health. That study was initially published in 2006. It didn't actually look to see whether antipsychotics were helpful. So the data was reanalyzed to see whether or not antipsychotics were helpful in treating psychotic symptoms. And they looked at olanzapine, risperidone, quetiapine, and placebo. What they found was that there was improvement with risperidone, olanzapine, and that the most improvement was seen with risperidone, especially in the hostility and suspiciousness and in psychosis. What they found was people stopped medication if they were being given a placebo for lack of the medicine working, and if they did stop an antipsychotic, it was because of side effects, which is what you would expect. They also showed that antipsychotics in general didn't actually help with the symptom cluster of depressive withdrawal from interactions, which overlaps with apathy. So one of the first questions I always ask when I'm thinking about giving a medicine and I'm thinking about stopping a medicine is, if I find a person who was helped by this medicine, when should I stop? When shouldn't I stop? And how should I think about that? Because especially now that everybody is very focused on decreasing the inappropriate use of antipsychotics, one of the things you have to make sure is that you don't decrease appropriate use. So if I have somebody who has dementia and who has psychosis or agitation and aggression, and we stop the medicine that seemed to have helped them, what happens? So this was actually studied in 2012. And what they found is that people who were helped with the medicine, the longer they were on the medicine, the less likely they were to have a relapse if it was stopped. And the more likely they were likely to have a relapse if it wasn't continued very long. And so with these particular folks, so these were all people who were treated with risperidone and who had decreased paranoia, agitation, aggression, and hallucinations. And when those symptoms were effectively treated, they tended to stay away the longer a person was treated. But it's also important to note that not everybody who was taken off the medicine relapsed. Some people responded to the medicine, and even after 16 weeks could be taken off of it, and 40%, so less than half, but still 40% of people did not relapse if they were taken off of the medicine at 16 weeks. And the longer they were treated, the less likely it was that people would relapse. This is just some data showing that the rate of mortality is higher for the older antipsychotics than it is for the newer antipsychotics. So just a word about what are the most dangerous medicines for older adults. Well, it turns out the most dangerous medicines, the medicines that lead to hospitalizations and emergency room visits, aren't any psychiatric medicines at all. The medicines that cause most drug-related hospitalizations in older adults are blood thinners, medicines like warfarin or Coumadin and aspirin, and then medicines that lower blood sugar like insulin or other diabetes medications. And then finally, if we look at what are the risks of atypical or the newer antipsychotics compared to antidepressants or compared to benzodiazepines like lorazepam and diazepam. Here was a study by a group, Dr. Hubricks and her group actually were expecting to find that the risks of atypical antipsychotics were greater than the risks of antidepressants, benzodiazepines, or conventional antipsychotics. And so this was published at the Canadian Medical Association Journal in 2011. And in fact, what she found was people who were treated with conventional antipsychotics, antidepressants, and benzodiazepines in general were much more likely to have non-cancer mortality, femur fractures, pneumonias, and heart failure. So in fact, the atypical antipsychotics of these four medicine groups weren't associated with the most of these adverse events. So no discussion of behavior disturbance related to dementia is complete without a mention of the dementia-specific medications themselves. And so I do think that the antipsychotic medicines used appropriately in appropriate doses with good supervision are needed at times for specifically agitation, aggression, paranoia, delusions, suspiciousness, fearfulness. However, I think overall, I would like to review a little bit of the evidence about dementia-specific medicines, which are very low risk and have moderate efficacy. And specifically, when I say that, I mean memantine, donepezil or Aricept, rivastigmine, galantamine. Those are the dementia-specific medications. In 2006, Cummings et al. Looked at a 24-week study of people who had moderate to severe dementia of the Alzheimer's type, and what they found was that people who had agitation, aggression, eating or appetite problems, and irritability and mood swings improved the most when they were treated with memantine. And what I thought was the most important thing from this study was that people who didn't have aggression at the time of the study were less likely to have it at the end of the study if they were on memantine than if they were on placebo. So that's sort of indirect evidence that there may be a preventative effect of memantine for aggression. The cholinesterase inhibitors, which are the oldest class of medicines to treat people with Alzheimer's and include donepezil, galantamine, and rivastigmine, there's pretty robust evidence that they reduce agitation and the need for antidepressants, anti-anxiety medicines, and antipsychotics. So if you're really concerned about the use of antipsychotic medicines for people who have dementia, I would like to strongly recommend that you consider looking at the dementia-specific medicines for those folks. And here in 2004 was just a look at rivastigmine, and it's an open label study, so everybody knew who was being treated, and they looked at people who had mild to moderate Alzheimer's, and they looked at people who were on an antipsychotic or on an anxiolytic medicine like lorazepam. And they followed them up 4 to 6 months later after they were started on rivastigmine. And what they found was lots of people could be stopped or have the dose decreased, and very few people needed to have an increased dose of antipsychotics or anti-anxiety medicines if they were on a cholinesterase inhibitor. So what are guidelines suggest, and what do other countries do? So in the United Kingdom, the National Institute for Health and Care Excellence, or NICE, they have guidelines that are widely looked at. And their recommendations about the dementia-specific medicines have changed over time. In 2001, they recommended that they be used until there was no effect and then stopped, which is a little hard when you're using something to tell whether it's having an effect or not without stopping it. But be that as it may, they were pretty commonly used in the UK. The donepezil in particular was used in the UK up until 2005, when they looked at the evidence, and they specifically were mostly looking at whether or not the dementia-specific medicines were helping with memory and cognition. And they decided that there was insufficient evidence to use them. So they recommended that. So this caused a lot of stress, may have caused an increase in symptoms in people. It certainly decreased the use of the medicines. And they went back and looked at it again in 2006 and found that there were people who had moderate Alzheimer's, and it was cost-effective and clinically effective to use medicines like donepezil. In moderate Alzheimer's, they were not so sure about mild or severe illness. And then more recently in 2011, they recommended cholinesterase inhibitors as clinically and cost-effective in mild and moderate Alzheimer's disease. They also, interestingly, recommended them for use in Lewy body dementia, and if non-cognitive behavior, so if behavioral symptoms weren't helped with non-pharmacological or antipsychotics, then you could consider using a cholinesterase inhibitor. So in the UK, they actually recommend trying antipsychotics before they recommend trying a dementia-specific medicine, which is sort of opposite of how we do it in the US. Canada looked at the evidence in 2013 and came out with new guidelines. And what they really felt, the evidence showed, their review, that cholinesterase inhibitors possess really a class effect. And so all of the cholinesterase inhibitors help across the whole entire spectrum of Alzheimer's disease. And they recommended and pointed out sort of moderate efficacy for behaviors and mild efficacy for cognitive symptoms. They also recommended them as a treatment option for dementia with Parkinson's disease. In 2015, in Europe, the guidelines recommended combined therapy of a cholinesterase inhibitor plus memantine. And again, what they noticed that there was beneficial effect in Alzheimer's disease for the combined therapy, and the quality of evidence was high for behavior and moderate for cognition. and that really dementia-specific medicines don't help with activities of daily living at all at this point, as far as we can tell. So that is sort of an overview of antipsychotic medicines, when to use them, how to use them, and what might be a better alternative when we're treating people with dementia and behaviors, which would be the dementia-specific medications. So I really appreciate everybody's time and attention. If there are any questions.
Maureen, we have a couple questions.
Okay.
One is, can you further discuss fall risks related to the use of these meds? So, as a class of medicines, antipsychotic medications are on the list of medicines that increase fall risk. Medicines in that class and on that list include everything from statins, cholesterol-lowering medicines, cardiac medicines, blood pressure and heart rate medicines, multiple psychiatric medicines. So antipsychotics are on the list of medicines that in general, if you just take all comers, it looks like people who are on these medicines have a higher risk of falling. Almost all of that data is what we call an association data. So when you look at the risk of falling, if you take everybody who falls and you look at how many people are on the medicine, more of them are on the medicine, but it doesn't actually tell you if the underlying illness is what increases the fall risk or whether it's being on the medicine that increases the fall risk. So that's sort of one of the things that we always have to try and tease out. And the best way to tell if a medicine is causing an increased risk of falling is if you just started the medicine and the person starts to fall or has an increased risk of falling, an increased number of falls after you start it, then it's quite likely that that medicine is related to it. On the other hand, if you have somebody who's been falling frequently and they're still falling frequently and you start the medicine and it doesn't change the amount they fall, then it's probably unlikely. So one study I did highlight showed in that group of people who were treated with risperidone, so these were people with Alzheimer's dementia, if they were treated with a dose of 1 milligram twice a day, 1 milligram daily, their fall risk was less than if they were treated with no risperidone or they were treated with 2 milligrams per day. And my sense of it and my opinion is that it's quite likely that what happened is that people who were treated with it were less agitated, they were less paranoid and delusional, and so they were not taking as risky actions, and that's what led to their decreased fall risk. And then the higher the dose went, the more likely it was that side effects would emerge. Okay. What about augmentation with mood stabilizers? Does this increase risk for mortality?
So mood stabilizers, and when people say that, they often mean the anti-seizure medicines like valproate or valproic acid, which is otherwise known as Depakote or Depakine, or carbamazepam, which is otherwise known as Tegretol. So those medications, which are basically anti-seizure medicines, they have many, many side effects. There are some older studies that suggested perhaps they would be helpful in treating behavior disturbance in people who have dementia, but more recent studies and in the Canadian guidelines and the European guidelines recommend against using mood stabilizers for behavior disturbance in people who have dementia. They do have major side effects, and especially in Alzheimer's, vascular dementia, Lewy body dementia, and Parkinson's disease dementia, they are unlikely to be first, second, or even third line choices for behavioral symptoms. There's more evidence that they harm than that they help. But that's for the population as a whole, so that doesn't mean a particular person can't be assisted with these medicines.
Okay. Are there studies regarding Divalproex used for people with dementia. Is this medication considered older or newer?
So divalproex, which is related to valproate or valproic acid, so again, the depakote-depakine family of medicines. Those are older medicines. Those medicines are not currently recommended for the treatment of Alzheimer's disease, behavioral symptoms related to Alzheimer's disease. There is one symptom cluster that those medicines seem to help, and that's impulsive behaviors. And there, of all the types of dementia where there is a small amount of evidence where they might be helpful, is frontotemporal lobe dementia or frontotemporal dementias. However, in general, most treatment has moved away from those medications.
Okay. If a patient is on amantadine, and now go ahead.
Amantadine, A-M-A-N-T.
Yeah, T-A-D-I-N-E. And now has a diagnosis of dementia. Does that medication need to be decreased or discontinued?
So amantadine is a medicine that is used for a number of things, most commonly for people with in the early stages of Parkinson's disease, but it can be used for other things. It can be used as for prophylaxis for influenza. But amantadine increases dopamine in the brain, and so it increases the likelihood of somebody having paranoia or delusions or hallucinations. And so as a general rule, I would recommend a trial of tapering somebody off of amantadine if they were on it, and then seeing how they do. Studies of medications tell us about population as a whole, but they don't actually ever tell us what's helpful for you as an individual person. So really the only way to know if a medicine is helpful for you is to try it in you and see if it works. And if you really want to know if it's helping, you can then taper it off. If the symptoms or whatever you were trying to help comes back, then you try it again. And if they go away, then it's quite likely that that medicine is very helpful for you at this particular point in your illness. What we call an on-off-on study.
Okay, we have, unfortunately, we only have time for one more question. And this question is, do you ever recommend cholinesterase inhibitors be discontinued, or do you keep them ongoing in order to potentially help with behaviors?
So cholinesterase inhibitors like donepezil or ribostigmine, the question is, when should you consider stopping them? If a person has had moderate or severe behavior disturbance as part of their dementia, I am unlikely to recommend stopping those medicines. If a person is having side effects, I think it's worthwhile to look at that and consider it. I think it's a very individual discussion. In people who have early disease, there is some suggestion that taking away a cholinesterase inhibitor may cause a loss of functioning that people can't get rid of. There was some very early studies suggesting that. But when you're using these medications to treat behavioral symptoms, there's not a specific reason to say, oh, you should never stop that, and it's not a good idea to restart it. You can always stop and then restart if you're treating behavioral symptoms. The key thing is you're going to have to monitor for up to 6 months after you stop the medicine before you actually know whether things are going to reemerge, symptoms are going to reemerge. It's not something like I stop it and then I know next week whether or not the symptoms have returned.
Okay. Unfortunately, that's all the time we have for questions. What we'll try to do for the remaining questions, there's a couple more. We'll try to get answers to the folks that have asked them. So just to wrap up, thank you for attending today's webinar. We hope you enjoyed it and gained valuable knowledge and information that will positively impact how you support people living with dementia. Please complete the evaluation that will be sent shortly, and we will also be sending out certificates and the slide presentation from today this afternoon. Thank you very much.